Evening. I appreciate everyone's patience. This is the first time we've ever done a dual, both in person and live streamed, and public comment in both areas, public hearing. So I appreciate everyone's patience as we get this set up, both those that have been waiting online and those that have been waiting so patiently in the auditorium with us. I will like to begin by letting our participants who are online knowing that, let them know that there are links to the full public notice and rate equalization approval letter are available on our HIP website. Anka Hinshaw with their Office of General Counsel will read a summary of the proposed changes and open the public hearing for comment. If anyone would like to make a public comment and you're in person, you need to sign up the back of the auditorium, or for those of you participating via the virtual option, place a comment in the YouTube chat and a member of the state team will provide you with the Zoom meeting information so you can join the Zoom meeting and so you can speak. My intention is that we'll do the in-person comments first, since we're signed up there, and then we will move into the individuals who are participating virtually. For those participating virtually, in a moment, I'll have a slide with instructions up as a reminder for how to request to speak publicly. Court order is taking down all the comments. They'll be reviewed by FSSA, summarized, and shared with CMS. I will turn it over to Anka Hinshaw from the Office of the General Counsel.
Thank you. Good morning. The Healthy Indiana Plan, commonly referred as HIP, is a health insurance program for qualified adults ages 19 to 64 who meet specific income levels. HIP has been a feature of Indiana's Medicaid program since 2008. Based on state statutory mandate, the HIP program has always paid providers at Medicare or 130% of Medicaid rates. Other Medicaid programs, fee-for-service, FFS, Hoosier HealthWise, and Hoosier Care Connect have been paid at regular Medicaid fee schedule. The final managed care rule published by CMS in November of 2020 disallowed the payment of disparate rates among managed care programs. As a result, FSSA submitted an emergency section 1115 waiver amendment and received approval on July 26, 2022 to continue paying HIP providers at the current Medicare or 130% Medicaid rates through December 31st, 2023. The emergency approval allows FSSA a limited amount of time to align and equalize physician and ancillary service rates among managed care programs and to comply with the final federal managed care rule. All current HIP eligibility limits and requirements will remain unchanged. This mandate does not include any changes to the current benefits, cost sharing, or delivery system. All HIP members will continue to receive a comprehensive benefit package through their managed care entity, consistent with private market plans and compliant with all mandated essential health benefits as required by the Patient Protection and Affordable Care Act, ACA. Enrollees receiving services under substance use disorder, SUD, and requested serious mental illness, SMI, component of the waiver extension will continue to receive services through the current delivery system. By January 1st, 2024, OMPP intends to have equalized rates among HIP, Hoosier HealthWise, Hoosier Care Connect, and FFS. FSSA shared an example methodology whereby aggregate provider payment levels will remain the same, with physician and ancillary rates decreasing in HIP and increasing in other programs. FSSA will continue to evaluate this and other equalization methodologies in the coming weeks and months. We look forward to stakeholder feedback on this item. 30-day public comment period opened on August 3rd, 2022, with the publishing of the public notice in the Indiana Register and will close September 2nd, 2022 at 5 p.m. Last week, this topic was presented on day one of the quarterly MAC meeting to the Medicaid Advisory Committee. Written comments may be submitted via email to spa@fssa.in.gov. That's PACOMMENT@fssa.in.gov via mail at 402 West Washington Street, room W374, Indianapolis, Indiana, 46204, to the attention of Lynn Mong, Lynn, LYNNEMONG. In addition, FSSA will host 2 public hearings during which the public may provide verbal comments. This is the second hearing. Now we are opening the hearing for public comment.
Thank you. Start us off, calling Emily Hinshaw, dentist, for public comment. Thank you. Sorry.
I'm Dr. Emily Horsha. I'm a general dentist. I opened Newberry Dental in 2017. For the past 5 years, I've done only root canals. Last year, 79% of my patients were on a Medicaid plan. Patients are referred to me from all over the state. They travel up to 2.5 to 3 hours for treatment. I see a large number of pregnant patients who are on hip maternity. Of my Medicaid patients, around 80% are adults. I have been in business for over 5 years, and to my knowledge, Medicaid has not increased any of their fees during this time. I understand that Medicaid needs to equalize their plans, but lowering the HIP plans to meet the significantly lower fee schedules will only reduce access to care even further. We are all facing the same issues in our practices: general inflation, supply cost increases, and higher wages. Many of us who accept Medicaid are booked out for several weeks. I am currently booked out over 6 weeks. Wages in my area have increased as well. You used to be able to hire someone fresh out of school with their radiology permit for $13 or $14 an hour. Now they are asking for $20+ an hour. Some supplies have quadrupled in cost during the pandemic. Like everyone else, I've had to absorb the cost without seeing an increase in office production. To combat these losses, I'm in the process of moving to an office with lower rent, with utilities included. If these changes to the Medicaid schedules go through, it will negate my savings and further decrease the bottom line of the office. For the first time in my career, I may have to reduce or even stop accepting Medicaid patients. I cannot reduce my overhead anymore without compromising the quality of care, and I refuse to do that. There are many offices facing all the same struggles I am who take a lower percentage of Medicaid. If their patient mix is lower than mine, and they're booked out for over a month, they may decide to drop Medicaid altogether. This will only reduce the access of care even further. They will have even longer wait times at the offices that do accept Medicaid. Those offices will become overwhelmed. The patients will have to wait even longer between cleanings, longer for their restorative appointments, and need more root canals and extractions. I know nothing that I've said here is groundbreaking. We all are here to say exactly the same things. Any reduction in HIP payments will result in a loss of access to care for many Indiana residents. Please reconsider decreasing the fees. I've always been very proud of Indiana's Medicaid programs and the number of dentists who are enrolled to treat these patients. I've built my whole career around serving them and serving this underserved population. I hope that I can continue to do so. Thank you for your time.
Thank you for your public comment. Jill Snyder is next.
Hi, I'm Dr. Jill Snyder. I practice in Frankfort, Indiana, which is Clinton County, about 40 minutes west of Indianapolis. I've been practicing for 30 years in Clinton County and been a Medicaid provider for over 25 years. I started as a Medicaid provider because a young lady who was 11 years old fell, knocked out about 6 teeth, and I had to put them all back together. And the only way I could get paid for that was to become a provider. Over those times, I've seen reimbursement be cut. It's increased, it's decreased, it's been stagnant. And my overhead has continued to soar, particularly since the pandemic. It's soared even more. Last year, I wrote off $191,000 $770.70 in Medicaid write-off. That's $191,000 that I could have put towards assisting the schools, assisting the community. I'm a private practice. I'm only there for myself practicing. I am not a corporation. We have the other offices in town that take Medicaid are corporate offices. I don't like the way they practice, and corporations are taking over the private practice. But that's another subject. Right now, my average write-off for a procedure is $134. Now, I would ask if anybody up in the panel, anybody in charge has had a raise in the past 10 years, because I would believe that everybody has gotten one. But if you ask any of the dentists sitting here or any of them on Zoom that take Medicaid, they will all say, no, we're taking a fee cut. I'm taking a reduction in my overall wages every year. Last year in July, I had to cut my new Medicaid off and say, I can't take any more. I will take care of the patients that I have, but I cannot take any more. As I said, even though I'm a general practice dentist, I only take children as Medicaid because I feel like they can't help their situation and I want to help them. But I can't keep doing that. I get reimbursed 25% of a filling. Trying to do a filling on a 3-year-old is a challenge at best. You have to have at least 2 people in the room at all times to be able to see them. And my expenses, my hard costs just for the supplies to do that are over $25. Then I add in my staff, and that's what I get reimbursed for, is my assistant and my supplies. I don't get paid to see that child. I have expenses. I have responsibilities to people too. And I invest back into my community. I just don't think there's really a connection that people understand what it costs to even see a new patient. A new patient on Medicaid, if I bring in an emergency patient, I get reimbursed $50.33, but it costs me $55 to bring them in. At this point, I can honestly say that I am looking at eliminating Medicaid completely. And now you're saying, okay, we're going to reduce your benefits even more, what you're reimbursed. Oh, I mean, I just don't see how the 1,106 children that I see in my practice that are on Medicaid are going to have a provider anymore. And I hope that you will not only consider increasing it more, not decreasing the HIP, but increasing other more, because our costs are going up and we need to have a regular increase. Right now, 43% is what I'm reimbursed. Next year, when I increase my fees, which happens every year, it's going to be 37%. Or I'm sorry, it'll be 40% and then 37%. It can't keep up. I appreciate your time. And I could talk for hours, but I won't.
Thank you, Dr. Snyder, for your comment. Next on our list is Dr. Jill Burns.
Thank you for allowing me to talk to you today. My name is Dr. Jill Burns, and I'm president of the Indiana Dental Association. The IDA is the Indiana's largest dental association with more than 3,000 members comprising 80% of all practicing dentists in the state. I've been practicing dentistry for 38 years, 7 years as a Navy dentist, and then 31 years in private practice. I've been a Medicaid provider since 2011. I'm here today to voice similar concerns to those expressed by many of my colleagues in the dental profession. I'm very concerned about the impact that OMPP's proposed rate equalization will have on provider retention rates for HIP. These patients with Medicaid and HIP need dental care, and they are finding it harder and harder to get that care in the state of Indiana because of underfunding. Dental health is total body health because the mouth is the gateway to the rest of the body. Neglecting your teeth can lead to devastating health consequences. I personally have sent patients back to their primary care providers because I found evidence of diabetes, heart disease, and cancer during their oral exams. Medicaid and HIP patients need dentists to be on the front line of their dental care and their health care. While I recognize the difficult task that is before FSA to establish rate equalization across all programs, I have concerns about any decrease in reimbursement in one program to offset costs for reimbursement in other programs. The decrease will have an adverse effect on provider participation in all programs. A colleague of mine, Dr. Leela Alter, cited at Wednesday's meeting a 2019 Bowen Center for Health Force Research and Policy Studies titled Indiana Providers Reported Barriers to Medicaid Participation, Physicians and Dentists. Out of the reporting sample of 1,604 dentists, nearly 60% indicated that they are not accepting new Medicaid patients. The number one reason cited for not accepting new Medicaid was due to low reimbursement rates. The IDA recently sent out a similar survey to its members on Medicaid participation rates. The survey came back with similar results. Of those respondents who indicated they do not accept Medicaid patients, 90% cited low reimbursement rates as the number one reason. Many of these providers were accepting Medicaid previously, but now have dropped out of the program. Over the last few years, many states such as Vermont, Kansas, Georgia, Mississippi, Missouri, Tennessee, Florida, South Dakota, Nebraska, Minnesota, Washington, Alabama, Illinois, and Wisconsin have taken action to reevaluate Medicaid dental reimbursement rates and implemented increases. In the new September issue of the Journal of the American Dental Association, there's an investigation titled Impact of Medicaid Dental Coverage Expansion on Self-Reported Tooth Loss in Low-Income Adults by Jason Semprini and George Wybe. The conclusion of the study, and I'm paraphrasing, is that Medicaid expansion with extensive dental benefits was associated with increased dental care, mostly extractions, among low-income adults. This finding suggests that greater access to oral health care previously unmet oral health needs for this population. This study is gathered from 19 states who expanded Medicaid coverage. I believe these findings are significant in support of Indiana increasing reimbursement rates. Like other health professions, dentistry has suffered the devastating effects of the pandemic. Increasing cost of supplies, workforce shortages, and increased demand for services have created exponential stresses on the industry. At this point in time, Medicaid reimbursement doesn't routinely cover my office's overhead either. As a small business owner with a staff I take care of and hope to retain, it is extremely difficult to treat Medicaid patients at such a loss. I no longer fabricate Medicaid dentures because the reimbursement doesn't even cover the fee to pay the dental lab to make them for me. None of my overhead is covered by these denture patients. In fact, instead of breaking even, it puts me in the red. Also, there are nonsensical rules such as a patient can only have one arch, like an upper or lower, made a year. I would have to make a denture for a patient for their upper and then wait a whole year to make them a lower, to match it. An overhaul of the system is needed. I am most concerned that any proposed equalization effort that results in a decrease in reimbursement rates to any program will have a tremendous impact on already diminishing provider participation rates due in large part to the reasons I've outlined above. It is worth noting, barring a few exceptions in 2008, Indiana dental providers have not seen a substantial increase in Medicaid reimbursement rates in 23 years since 1999. While I understand and appreciate FSSA's efforts and the task before them, there must be a parallel conversation on increasing the completely outdated Medicaid reimbursement rates with a January 1st, 2024 implementation. In closing, A recent 2022 report by the government's Public Health Commission has shown that Indiana consistently ranks in the bottom percentile in the whole country in terms of investment in public health. Given this reality, perhaps the conversation should not be which programs do we reduce funding for, but rather which programs should we be investing in? Are we going to continue to neglect the health of those Hoosiers by decreasing rates even further? I hope and pray that we do not. Thank you for your time.
Thank you, Dr. Burns, for your comment. Next, we have Ed Rosenbaum.
Morning, Ed Rosenbaum, Director of Professional Services for the Indiana Dental Association. I've been in that position for 15 years, since December of 2007. I too speak in favor of equalizing the rates by increasing the non-HIP programs up 30% to the current HIP program. I realize that sounds like a big ask, but I hope with my comments today and by what the other dental providers have commented, that you can understand why we're where we're at today and why we're a little bit different. Dentistry is a unique creature, a unique entity in that we're not part of Medicare. You do not see other physicians here, other health providers, it's dentists. And the reason why is because our rates are tied to Medicaid that were artificially or set by some form or fashion back in 1999. Those providers that are paid by Medicare get annual or some type periodic reviews and get increases as the federal government determines for Medicare. Dentistry does not get that advantage. We have continued to suffer with the same rates that were applied in 1999. And per Dr. Leila Alter, who sits on the Medical Advisory Committee, those 84 of those rates were increased slightly in 2008. And that's been it for dentistry when it comes to their fees. So even though it sounds like a big ask to go from 30% increase for the non-HIP programs, it's really not when you realize it's been 23 years since we have increases. I won't go into the factors again, inflation, PPE costs, all of that's already been cited. Why is it so hard? We have met with FSSA numerous times through dental advisory panels, through in-person meetings. We've had agreements where we thought it was going to go through, and then all of a sudden, for whatever reasons, the rate increases for dentistry got shot down. It's never easy for the state to increase rates. We can try to go to the General Assembly and do it that way as well, but this is a prime opportunity for the FSSA and for us to work together to get these rates increased and get the non-HIP programs back up to where they should be. So in 2014, Pence's administration, Governor Pence, realized that the HIP program was not going to be sustainable if they paid the same rates that they paid currently for traditional Medicaid. I got to make sure I say my names right. So the state government decided we need a 30% more to take care of the adults and to have a program that the providers are willing to come and the adults are willing to find providers to go to. I don't know how the state came up with the 30% in 2014, but that's what they did. So now we still have asked the non-HIP programs to suffer along with rates that have been increased one time, 84 of them out of the 200 or 250, how many procedures there are in the code book. One up increase of 84 of those in 2008, and the rest has been the same since 1999. So again, I ask that you look at the differences between dentistry and the other organizations. Look at what the state did in 2014. Ask yourselves why. Why did they do the 30% increase then? It's always difficult to raise rates. The state is saying they have these billions of dollars, they're sending money back to taxpayers. As already been quoted, public health, Indiana rates very low in public health. We need to take care of our non-HIP folks just like we do with our HIP folks. So again, I speak in favor of equalizing the rates 30% across the board for not all non-HIP programs to bring them up to the HIP rate. Thank you very much.
Thank you for your testimony. I appreciate it. Next, we have Dr. Nicole Woodell.
My name is Nicole Woodell. I am president of Woodell Pediatric Dentistry. I'm past president and current treasurer of the Indiana Society of Pediatric Dentistry. I'm I'm speaking today to petition support for increased Medicaid reimbursement, in particular for pediatric dentistry. I have been practicing dentistry since 2008 and became a pediatric dentist in 2010. I joined my family business, Woodell Pediatric Dentistry, in 2010 and bought the practice from my father in 2014. My father had been running the practice since 1980, taking mainly Medicaid patients. My sister Lauren Woodell bought his 2 other practices. The family business again started in 1980. Our mission statement is to provide the highest quality care to the children in the Indianapolis area. We aim to make dental visits easy and enjoyable to ensure a lifetime of healthy smiles. I encourage the state of Indiana to continue to support Indiana's children's dental health. Investing in children's dental health now can only reap benefits as these children become adults. Every visit, we strive to educate parents and patients to achieve better oral health. Our success as a pediatric dentist is graduating an 18-year-old to adulthood with the tools for continued excellent dental health. Dental caries is the most common chronic condition of childhood. Untreated caries can result in time off school, pain, poor quality of life from everyday discomfort, and potentially life-threatening infections. This also results in unnecessary ER visits and costs. As pediatric dental specialists, we have additional training in behavior management techniques, sedation, and general anesthesia for children with dental decay that are medically compromised, unable to tolerate dental treatment in the chair, and special needs children. Access to quality dental care is my passion. We are the dental specialists that provide early dental treatment and education. This education instills lifelong healthy habits and reduces government costs once they reach adulthood. My practice is 80% Medicaid. As a Medicaid provider, current times have provided financial challenges. My pediatric dental practice has not recovered from COVID and OR hospital block time closures. Hospital block time closures occurred March 2020 to August 2020. During that time, I was unable to do any of my general anesthesia cases. It also occurred during December 2021 to March 2022. I used to have staff privileges at Riley, St. Vincent, IU North, and Tipton. Now I only go to IU North and Tipton. Yes, you heard me correctly. My inner city Indianapolis children will drive all the way to Tipton, Indiana to get anesthesia done. Our family practice has downsized considerably. One of our 3 offices has shut down. Of the 2 practices remaining, only my practice accepts new Medicaid patients. It is difficult to recruit staff that want to work with Medicaid patients. This is pediatric dentists and hygienists, assistants, front office staff. They do not want to work with Medicaid patients due to low reimbursement, low parental appointment compliance, and high administrative burden. Now we have multiple state entities, HP, involved, DentaQuest, Hoosier Care Connect, to credential with and work with claims. Since the split to multiple entities, I've had to hire extra administrative person. There are also increased fees to accept state payments electronically. We also have to pay for translators. At Tipton, at IU North, the translator over the phone did not show up, so I personally paid for the translator so the patient could get the treatment done. So if you figure in, we have a Burmese patient, just imagine I'm like negative like 300 on that initial exam with the translator and the reduced reimbursement. You think at least at a hospital setting, they would have a translator for a patient, especially since one was scheduled. They also have, so our company used to employ at least 15 pediatric dentists. Now I employ 5. I only have 2 full-time associates. Every Saturday, I would employ 8 hygienists. Now I'm lucky to get 5. We've had to shut down half the Saturdays we work because we do not have providers or staff to deal with our patient volume. We normally have worked every Saturday since 1980. Since 2020, we have decreased our year total recall number by 3,000 patients. This is an access to care issue. In addition to staff shortages, we have experienced considerable inflation. We have had to compete for staff from cash insurance offices that can afford to pay their employees more. To retain my staff, I've had to give my hygienists 166% raise and assistants 125% raise. Due to inflation, all my employees have received at least a 10% raise. Staff is not the only cost. Our dental supplies have increased 30%. My rent has gone up. We pay for translators, postage, all expenses have increased from our operating budget, except for the doctor pay. All my associates have been understanding about that. Thirdly, in addition to staff and budget challenges, patients have experienced decreased specialty access to care. I only know of one periodontist and one endodontist I can refer patients to. There are several oral surgeons that have restricted Medicaid patients. You can schedule them, but right now when I call IOMSA, they can't get my patient in until February. This has just started happening this summer. Our usual oral surgery referral, IOMSA, has a long waiting list. Don't all children deserve access to the highest quality of care? Doesn't a special needs child deserve a board certified oral surgeon to address their dental pain in the hospital under general anesthesia safely if needed? This is compromising quality of care. As a pediatric dentist, we take an oath, like all health providers, to take the best care of our patients. There are many times when I feel like this is out of my hands to get to the right dental specialists. As owner of Woodell Pediatric Dentistry, I take great pride of taking care of children as I would my own. I am very lucky to have hardworking, experienced, and loyal staff over the years. I would greatly support from Indiana government to raise reimbursement for dental procedures for children. I believe this will improve access to care. I am very concerned about future access to dental care if present reimbursement rates do not change. It has been at least 23 years. I also support Medicaid reform of the codes. I would greatly suggest working with dental providers in the next month to figure this out. Thank you.
We have Dr. Eva Sparker.
Hi, I'm Dr. Ava Sparker, and I drove down from Granger, Indiana this morning, which was almost a 3-hour drive. I have been a Medicaid provider since 2007. I have worked part-time at a lot of FQHCs because this is a population of patients that's very close to my heart. I'm here today because for a couple of different reasons. Number one, the decrease in the HIP fees, and then also the Medicaid equalization. The Medicaid equalization, definitely the fees for the Medicaid need to go up. That's just plain and simple. The HIP, we're having a lack of access to care for our patients. I have had to, with my office, I'm the CEO and president of my own practice, 32 Pearls Family Dentistry. And with my practice, we have had to limit within the past couple of years the number of Medicaid patients that we accept. Considering the reimbursements are so low, we wouldn't be able to make bills. With that, there have been so many providers in the area who have stopped accepting the insurance due to the lack of reimbursement rates. So we have gotten an influx of people trying to get into our practice. As of right now, for a patient to get into our practice, we tell them it's at least a 2.5-year waiting list. Yes. We have patients who are calling around our entire area to try and find providers. They're telling us that the only providers that they can find are down in Indianapolis. These are patients who cannot find help, who cannot afford health care. And we know they can't afford gas. Okay, today I started out driving down here with 1/4 of a tank of gas, and I had to fill it up, and it was over $60. I can't imagine somebody who has absolutely no funds being able to pay for their gasoline to come down here every single time they need an appointment, because there's no way they can get everything done in one appointment, because the patients that we're working with are not patients that are able to see a dentist every 6 months and maintain preventative care. Medicaid doesn't even pay for that. Medicaid for adults, or HIP for adults, covers 1 cleaning a year, not even the 2 cleanings a year, 1 debridement a lifetime. Okay, scaling and root planing, 1 time. Okay, so these are patients that are higher risk and lower funding, less access, and we're going to be dropping things even further. We had to stop providing dentures and partials for patients because the lab fees cost more the reimbursement. And the patients call us and they're crying, or they're sitting in my chair and they're crying. And I'm like, I'm sorry. I can't do it. I can't provide free care for everybody. We'll have to shut our doors. Right. So they can't get their dentures. They can't get their partials. They only get one cleaning a year. These patients, the adult patients that are on the HIP, there's so many different plans. There's HIP Plus, HIP State Plus, there's HIP Basic, and then we've got all the different Hoosier HealthWise, Hoosier Care Connect. And with each of these, it's not one standardized system. It's so many different systems that we have to log into and credential with. The amount of administrative staff that we have to train and actually get to stay on board with our teams to be able to handle this is outrageous. We spend so much time, and if you're in network with these insurances, you have less of a filing deadline than you do if you're not in network with these insurances. So if it shows that somebody has a primary insurance and the state insurance is a secondary insurance, we have to wait until the primary insurance gets back to us to let us know how they plan on paying anything, if anything. And then at that point, then we get to file. From that point, we only have a 90-day period of time. So if there's any hiccup, any problem, if the patient accidentally signed up for their regular insurance, their primary insurance with their middle initial versus what we have on file for their state insurance, they will bounce that back, and then we've missed the filing deadline and we don't get paid for those appointments. It's a problem. It's a real problem, to the point that I just found out about this meeting 2 days ago. And I decided that I was going to take the time to drive down here to make sure that I could give my perspective along with my other colleagues that this is a huge lack of access problem due to the lack of fee reimbursement. I went to lunch yesterday with a couple of my colleagues, and somebody from Angola said that her patients are driving from Fort Wayne to Angola, and she too has a long waiting list that's over 2 years for new patients. These people have nowhere to go, and they're going to have less places to go now that everything's gone up. And we've been having the discussion in the past 2 weeks about potentially dropping as providers because we're unable to make the ends meet and make things make sense with these reimbursement rates being so low. Again, I have been a provider since 2007, and it has cost me like crying the past couple of weeks thinking about how I would be another person who would drop this and they'd have even less places to go. Because it's devastating. It's devastating to our communities. It's devastating to the population. The communities that are served by this, yes, we've got the children, but we also have the adults. We have the pregnant ladies. We have the disabled people. And with these people, especially the people with disabilities, having them come into an operatory. And just to give you an idea, the reimbursement rate for a cleaning, for an adult cleaning, is $47. The going rate right now for hygienists is $40 and up. So effectively, they're going in there to do a cleaning, and it doesn't cover our costs at all. And on top of that, with these disabled patients, it is doing damage to our physical health, being able to see these patients because we're unable to get them into positions that make sense for us to be able to treat them properly. So on top of us not being compensated for it, the doctor bills of having to go to the chiropractor and everything else like that, because you've had somebody who's folded in half in a wheelchair and you're doing your very best and you're doing your darndest to help them because there's nowhere else for them to go. So thank you for your time. I'm sorry for being so emotional, but I did drive all this way just to make sure that you guys heard another perspective. Thank you.
Or we don't have anyone online, just as a reminder for those of you who are listening online, if you go ahead and comment that you would like to testify verbally, you'll be sent the instructions for how to access Zoom. Also, I understand that the phone number is posted in there, so you can also just dial in. But if it's a heads up, then I'll know to call on you. So I want to remind everyone that there is the availability also to submit written comment. You can comments in writing, either to 402 West Washington Street, room W 374, Indianapolis, Indiana, zip code 46204. Attention, Lynn Mong. You can also email to spacomment@fssa.in.gov. That's spacomment@fssa.in.gov. We'll go ahead and give it a few minutes before closing out this hearing, waiting to see if we have anyone join online or if any other individuals join us in the auditorium. We'll go ahead and close out the public hearing. Thank you for all who testified. Lynn and Madison will stay here in case any other individuals arrive, but we appreciate everyone who participated today. And again, as a reminder, public comments can be made on this waiver through September 2nd, 2022 at 5 p.m. Thank you.